Hola, muy buenas. Bienvenidos a este Cardio TV que organizamos desde la Casa del Corazón y que va dirigido a hablar de un tema muy importante como es la prevención cardiovascular. Cuento y tenemos el honor de tener aquí en esta mesa a Carlos Guijarro, que ya lo conocemos, es internista, jefe del Servicio de Medicina Interna del Hospital Universitario Fundación de Alcorcón y en la actualidad es presidente de la Sociedad Española de Aterosclerosis. Y tenemos el honor de contar con Philippe Gabriel Stech, bien conocido por todos, es un cardiólogo de París, es en el Instituto Universitario de Francia, Chair Innovation Professorships, en el Instituto Universitario de Francia, y es jefe de cardiología en el Hospital Bichat Claude Bernard, París. Thank you for coming.
Thank you.
Really welcome to our house. Y lo mismo para ti. Yo voy a hacer la introducción en español y luego obviamente nos cambiaremos al inglés porque la presentación va a ser esto. Como sabéis, a mí me conocéis, soy Luis Rodríguez Padial, cardiólogo en el Hospital de Toledo y en la actualidad soy presidente de esta sociedad. El objetivo de este CardioTube es hablar sobre la eficacia y seguridad de icosapento de etilo en síndrome coronario agudo reciente, a raíz de una publicación en el European Heart Journal liderada por Gabriel Stech, que arroja luz muy importante sobre en qué circunstancias el icosapento de etilo puede ser especialmente útil para reducir la morbimortalidad de los pacientes, ¿no? La presentación la hemos dividido en dos partes breves. Una yo voy a hablar un poco de la importancia del riesgo residual. Después el profesor Guijarro nos va a hablar sobre el papel de la inflamación en la arteriosclerosis y el grueso de la charla, como no podía ser de otra manera, de la tarde, pues lo va a hacer el profesor Stech para presentarnos los datos de icosapento de etilo en los pacientes con síndrome coronario agudo reciente, incluidos en el estudio fundamental, ¿no?, del fármaco, ¿no?, del Reduce-IT. Para hacer esta introducción, está claro que los ácidos omega-3 tienen ya una cierta trayectoria. Empezaron en los 70 con estudios iniciales sobre los individuos que comían alimentos con ácidos grasos omega-3 que reducían la mortalidad. Luego se hicieron estudios observacionales sobre el consumo de pescado. Luego se utilizaron para la reducción de la hipertrigliceridemia los omega-3 como los niveles como un factor de riesgo, en este caso reduciendo los eventos, digamos factor de riesgo negativo. He marcado ahí el estudio GC Prevención, porque por lo menos para mí y para la mayoría de los cardiólogos fue cuando empezamos a ver que esto podría tener un impacto en la reducción de la mortalidad de los pacientes con infarto, que luego pues no se confirmó en otros estudios y al final se habían metido en el terreno de la reducción de los triglicéridos en pacientes tratados con estatinas. Hasta que viene el estudio Reduce-IT, ¿no?, que no voy a entrar en mucho detalle porque se va a comentar ahora, pero en lo que vemos que un ácido graso específico en unas dosis específicas, insisto en ello, pues es capaz de reducir la morbimortalidad cardiovascular de una manera llamativa, importante. Y eso yo creo que ha puesto sobre la mesa esta nueva estrategia terapéutica. Porque somos conscientes de que los pacientes con enfermedad coronaria le controlamos con fármacos que reducen el colesterol LDL, pues un 25-35% de su riesgo, pero queda la gran mayoría, 3/4 al menos, con un riesgo residual que evidentemente explica en parte la mortalidad que siguen teniendo estos pacientes, mucho más elevada en los primeros meses después de un síndrome coronario agudo, como comentaremos ahora, y sobre lo que de momento, hasta que hemos tenido icosapento de etilo, pues no hemos podido actuar claramente sobre este riesgo, ¿no? Y este riesgo residual tiene distintos componentes, evidentemente, que sepamos, seguro que hay alguno más que no controlamos todavía, ¿no? Pues tenemos un riesgo de colesterol residual, porque no todos los pacientes entran en objetivos. Luego tenemos un riesgo inflamatorio residual, que utilizamos un marcador clínico de la PCR de alta sensibilidad, riesgo trombótico residual, riesgo de triglicéridos residual y la LPA que está ahí, que sabemos que es un marcador de riesgo importante y que estamos esperando a ver primero que lo podamos reducir, que eso parece que sí ocurre, pero que reduciendo la lipoproteína pequeña disminuyamos los riesgos, ¿no? El Reduce-IT, como veis en la parte de abajo, pues realmente tendría en cuenta el riesgo inflamatorio residual, riesgo trombótico y el riesgo residual de los triglicéridos, que en principio donde parece que actúa, aunque eso lo comentaremos posteriormente. Tenemos el fármaco, el icosapent de etilo, ya en el mercado desde septiembre y bueno, pues lo estamos empezando a utilizar. Pero muy recientemente ha surgido datos que lo vuelven a poner en valor en un contexto claro, ¿no? Entonces, ahora yo le voy a pedir al doctor Guijarro que nos haga también un pequeño comentario sobre el riesgo residual. ¿Dónde está? Entonces, el mecanismo de acción por el que pueden actuar, ya veis que son el icosapent de etilo, que puede actuar, pues, como he dicho antes, en distintos aspectos, que actúan sobre la placa de ateroma, ¿no? Y te doy, Carlos.
Muchas gracias.
Sabes, de riesgo inflamatorio
en castellano o en inglés.
Él entiende español, más o menos, porque hemos descubierto, no lo he dicho, pero somos casi paisanos de Toledo, luego lo podemos explicar, dejamos eso ahí en clave y luego ya nos pasamos al inglés, ¿no? Yo creo que si te parece.
En tout cas, c'est un plaisir de partager la sesión avec el profesor Steck y vamos a continuar. Muy bien, ya lo mencionó antes el doctor Rodríguez Padial, que hablamos del extraordinario éxito que hemos tenido con el tratamiento hipolipemiante, fijándonos en la franja verde de la presentación, que es la reducción de eventos cardiovasculares. Pero quizá la expresión que a mí no me gusta, aunque está muy generalizada, es hablar de riesgo residual, porque no es un residuo lo que queda de riesgo de los pacientes, sino que es la inmensa mayoría de los pacientes en los cuales no le ofrecemos un beneficio en reducción en términos cardiovasculares. Y yo me gusta expresar la expresión riesgo persistente, persistent risk, porque transmite con mayor potencia la cantidad de pacientes a los cuales no les ofrecemos un beneficio con el tratamiento hipolipemiante. Incluso si le añadimos sobre los ensayos con estatinas el beneficio adicional logrado con los inhibidores de PCSK9, más de la mitad de los pacientes siguen teniendo complicaciones cardiovasculares que no hemos logrado evitar objetivamente tratando de reducir el colesterol LDL, que es obviamente una de las dianas que más éxito ha tenido, pero que no es la única a la que deberíamos atender. Y en ese sentido me han pedido que haga una breve introducción para hablar de inflamación en la arteriosclerosis y me gusta citar algo porque parece que es una afirmación relativamente moderna y puesta de moda ahora mismo, pero esta es una cita literal de una presentación de un autor muy conocido en la historia de la medicina que habla que no tiene ninguna duda en colocarse del lado de la visión antigua diciendo que la inflamación es una parte integral del proceso ateromatoso. Y esta afirmación es ni más ni menos que del siglo XIX, de Rudolf Virchow, de manera que es algo que podemos considerar una nueva oleada de, entre comillas, de modernidad, pero que en realidad está ya referida en la historia de la medicina hace más de 100 años. Y en ese contexto hay un montón de estudios, he elegido un par de ellos sencillamente a modo de ilustrarlo, de ensayos clínicos de pacientes tratados con estatinas en los que se ha intentado evaluar cuáles son los marcadores que nos indican el riesgo que persiste. Y en este caso concreto les muestro una publicación reciente de Lancet, donde se puede apreciar cómo efectivamente, tanto para muerte cardiovascular como muerte por cualquier causa, los niveles de colesterol LDL son muy pobres predictores divididos por cuartiles del desarrollo de muerte cardiovascular o de muerte, y sin embargo los niveles de proteína C reactiva ultrasensible son extraordinariamente predictores tanto de muerte cardiovascular como de muerte por cualquier causa. Y se lo ven en la parte derecha de la figura, tomando como referencia los niveles que hasta hace muy poquito consideraríamos como óptimos para reducción de complicaciones cardiovasculares, vemos que en los eventos cardiovasculares en este ensayo clínico no había diferencias en los pacientes por encima y por debajo de 70 miligramos de decilitro de colesterol LDL, siempre que tuvieran la proteína C reducida por debajo de 2 miligramos de decilitro, mientras que independientemente de si alcanzábamos o no el objetivo de 70 miligramos de decilitro, aquellos sujetos que tenían algún marcador de inflamación ligera, pero evidente, con una mínima elevación de la proteína C reactiva, sí tenían mayor riesgo de desarrollar complicaciones cardiovasculares. De manera que es plausible pensar que en pacientes en prevención secundaria, a los cuales estamos tratando ya con estatinas, quizá vamos a obtener una diana terapéutica mucho más accesible si nos dirigimos hacia la inflamación que hacia determinados niveles de colesterol LDL. Pues bien, como todos saben, tenemos muchos marcadores potenciales de aterosclerosis asociados a inflamación. En concreto, aquí ven en las gráficas que tanto la elevación de la proteína C reactiva como la elevación de interleucina 6 tienen un valor predictor muy similar a la hora de marcarnos pacientes de mayor riesgo cardiovascular a lo largo del tiempo. Y como es bien conocido, ambos marcadores de inflamación van muy en paralelo. Si se eleva la proteína C reactiva, se eleva la interleucina 6. Ahora bien, ¿cuál de ellos, si alguno, podría ser una diana terapéutica interesante? Yo creo que en esto nos ilustran muy bien estudios de alteración mendeliana que han demostrado que, en efecto, existe una asociación entre los niveles de cualquiera de estas moléculas que estamos mencionando, pero que no ocurre para proteína C reactiva. Los estudios de la autorización que nos indican que se eleva la PCR por causas genéticas a lo largo de toda la vida no muestran mayores complicaciones cardiovasculares, mientras que lo contrario ocurre para la interleucina 6. Estudios de la autorización mendeliana con pacientes con elevación natural de interleucina 6 tienen más complicaciones cardiovasculares. De manera que, siendo ambos excelentes marcadores de inflamación, probablemente la diana terapéutica no va a ser la PCR per se, pero sí puede ser la interleucina 6 o la interleucina 1, como ya mencionaste antes en el estudio CANTOS. Y luego, ya para cerrar una breve introducción, he puesto un ejemplo de prevención secundaria. He elegido ahora un ejemplo de prevención primaria de un trabajo español, del que todos ustedes conocen, que es el estudio PREDIMED, sobre el efecto de la dieta mediterránea en la prevención de complicaciones cardiovasculares. Pues bien, en este estudio también se puede observar claramente cómo los pacientes que tienen niveles de colesterol LDL en prevención primaria aparentemente correctos, pero con niveles de colesterol residual, que es un marcador de lipoproteínas ricas en triglicéridos, tienen mayor riesgo de complicaciones cardiovasculares. Del mismo modo, lo pueden ver aquí, tanto con elevación de proteína C reactiva como elevación de colesterol residual, tenemos marcadores potentes de desarrollo de complicaciones cardiovasculares en los cuales la presencia de triglicéridos, la presencia de colesterol en VLDLs es un predictor mucho más potente de complicaciones cardiovasculares. De manera que, después del éxito que hemos tenido, aunque no del 100%, pero importante, en la reducción del riesgo de complicaciones cardiovasculares, teniendo como diana terapéutica el colesterol LDL, y en el momento actual se nos abre la puerta de que otras lipoproteínas, las lipoproteínas ricas en triglicéridos, sean marcadores de riesgo como diana terapéutica, y asimismo la presencia de marcadores de inflamación que con frecuencia van juntos. De manera que, recapitulando mi presentación, hemos tenido un éxito con la diana del colesterol LDL, pero más allá del colesterol LDL tenemos las lipoproteínas ricas en triglicéridos, que sin duda son un marcador, ya veremos cuánto de diana terapéutica per se. Tenemos marcadores de inflamación y de trombosis que ya exceden nuestro tema de hoy para dirigirnos específicamente a nuevos resultados con el icosapento de tiro en el síndrome coronario agudo. Gracias.
Muy bien, muchas gracias, doctor Guijarro. And now we are going to change to English, into English. So I'm going to ask Dr. Steck to present and to discuss with us the data he had just recently published in European Heart Journal about the effect, positive effect, I think, of icosapent ethyl in patients with acute coronary syndrome, included in the trial, the principal trial.
Thank you very much. First of all, it's a pleasure and an honor to be with you in Madrid today and share this conversation. These are my disclosures. I must acknowledge I was in the executive steering committee for REDUCE-IT, so I was directly involved in gathering this data. Let me start with a little background. Why did we do REDUCE-IT? And it's something that we planned literally more than 10 years ago, because we started working on this in 2011, 2012, so it's been quite a while. As you know, the results of trials testing omega-3 fatty acids for cardiovascular risk prevention have been at best mixed. They were quite inconsistent. One of the trials that stood out and that gathered our attention was JELIS, which was a Japanese trial comparing a relatively high dose of EPA, purified EPA, 1.8 grams per day, in Japanese hypercholesterolemic patients. It's a large trial of more than 18,000 patients, and it showed quite a dramatic reduction by approximately 20% of coronary events. And this was consistently observed in the primary prevention cohort and the secondary prevention cohort. Now, this trial was done almost 20 years ago, so there are issues with the interpretation of the data. It was not double-blind. There was no placebo. It was mostly men. And the use of statins at that time was quite minimal and inconsistent in the trial. So we thought it'd be interesting to try a similar type of therapy in a modern environment and to purposely select the population that might be deriving the greatest benefit and be at the greatest residual risk, identified by being on statin with controlled LDL cholesterol on statin and with elevated triglycerides, which we expected would be one of the features that would identify benefit or potential benefit from EPA. And so we elected to include in REDUCE-IT patients who are statin-treated, men or women, above 45 years of age, either with established cardiovascular disease or with diabetes mellitus and at least one other risk factor. This would be the primary prevention cohort. And they had to have TGs between 150 and 500, and an LDL cholesterol considered to be reasonably controlled between 40 and 100. Remember, the trial was designed in 2011, so these are not the modern day targets for LDL cholesterol, but they were at the time. And it's a double-blind placebo-controlled trial with icosapent ethyl versus placebo. And to maximize the chances that we would see something, we decided to use a high dose of EPA, 4 grams per day, so 2 grams twice daily. So that if the results were negative and we were totally in equipoise when we started off, at least it wouldn't be an issue of too low a dose. And so we did the trial. It's an international trial, and we had to wait until the results. And when we unblinded the results, we were as surprised as anybody, I can tell you, by the magnitude of the benefit we saw. The primary composite endpoint, which is a quintuple composite of CV death, MI stroke, revascularization, and unstable angina, showed a 25% relative risk reduction. But I think that more than the relative risk reduction, what is meaningful is the absolute risk reduction of almost 5%, which means that over the duration of the trial, the number needed to treat is only 21. And I don't have to spell the number of 0 behind the p-value, but it's very, very significant. It's a very positive trial. Now, some may say, well, coronary revascularization and stable angina are softer endpoints. What about a more traditional, harder composite outcome of CV death, MI, and stroke? Well, we also saw a 25% reduction in CV death, MI, and stroke. Absolute risk reduction of 3.6%, number needed to treat 28, and again, a highly statistically significant p-value. So there's no question that the trial is dramatically positive. Now, if we have this efficacy, what about safety? So a couple of issues came out. Overall, the treatment emergent adverse events are quite similar between the two groups, but there's a slight difference in bleeding. There's actually slightly more bleeding with icosapent ethyl compared to placebo, 11.8 versus 9.9. Fortunately, when you look at the details for the bleeds, if you look at the serious bleeds, serious adverse events, it's only 2.7 versus 2.1%, so it's a modest increase. And there's no increase in intracranial bleeding. In fact, there was no intracranial bleeding with icosapent ethyl compared to placebo, 0 in the icosapent ethyl arm. And central nervous system bleeding was no different, 14 versus 10. The other side effect is a slightly higher incidence of atrial fibrillation or flutter. There are many ways you can define these. For instance, if you look at atrial fibrillation or flutter that was positively adjudicated and required at least 24 hours of admission, it was 7.9% with icosapent ethyl versus 6.1% with placebo. And this is highly statistically significant. So it's very clear. And in fact, we've learned since that this is not solely in REDUCE-IT. It's been shown in other trials of omega-3 fatty acids. So I think it's quite consistent. This is an analysis that was published a couple of years ago by Boris Gencer, where he looked at all of the recent large trials of omega-3 fatty acids. And as you can see, there's a consistent increase across the trials. And when you do the meta-analysis, it's approximately a 25% increase in the risk of atrial fibrillation or flutter with omega-3 fatty acids. Again, consistent across the populations and the trials. And in fact, it's also dose dependent. So I think this is true. There's no question about this. Now, because we saw such a benefit overall, but we saw bleeding and a risk of atrial fibrillation, we thought it'd be interesting to examine the recent ACS subgroup in REDUCE-IT. Why? First of all, recent ACS is a high-risk population, which is likely to derive even greater preventive benefit from icosapent ethyl. Also, and importantly, recent ACS patients receive potent antithrombotic therapies. They generally receive dual antiplatelet therapy, and as such, they may be at greater bleeding risk than the overall trial population. And the question was raised, should we refrain from giving icosapent ethyl to recent ACS patients given the concerns with bleeding? And therefore, we thought it'd be interesting to examine both the efficacy and the safety of IPE in this population subset from the trial. So we extracted from the roughly 8,000 patients of REDUCE-IT this subset of patients who had an ACS less than 12 months ago. It's 840 patients. And they have the typical clinical characteristics of that population. Their mean age is 60 years of age. It's a vast majority of males. Approximately a quarter of the population was from the United States. They were well treated with statins, with 2/3 being on moderate statin intensity and 1/3 on high intensity statin. A third of the population was diabetic. And the delay between the recent ACS and randomization was a median 5 months. But it ranged from 3 months to 8 months in the 25th and 75th percentile. This was a very well-treated patient population. The rate of use of the various secondary prevention medications is high. And note that 8% of the patients were on anticoagulant alone, 6% were on anticoagulant plus antiplatelet, and 2/3 were on 2 antiplatelets. When we look at the results, we get dramatic benefit in that subgroup. The hazard ratio is 0.73, which means it's a 37% relative risk reduction, so dramatic risk reduction. An absolute risk reduction of 9%, number needed treated of 11. So this seems to be a really nice hot spot in the data for benefit. If you look at the key secondary composite endpoints, CVIDES-MI and stroke, again, 36% reduction, absolute risk reduction 6%, number needed to treat 16. Again, highly statistically significant. We can look at not only first events, but recurrent events. This is similar to what we did in the overall trial. And again, a very consistent picture. I won't go into the details of the numbers, but we get a consistent reduction in total events, just like we saw a reduction in first events. Now, if we look at the totality of the population, I think it's interesting to note that in red, you have the primary composite endpoint in this forest plot for the overall trial population, 25% relative risk reduction. In blue, you have the recent ACS, less than 12 months subset. And as you can see, this is the group where the hazard ratio is the lowest and the relative risk reduction is the greatest. This is the subgroup of patients who derive the greatest benefit in the entire trial. Now, what about bleeding? Well, somewhat surprisingly, there was no increase in bleeding. In fact, not only was there no increase in bleeding, numerically bleeding was lower with icosapent ethyl than with placebo, although not statistically significantly so. And we can discuss why that is maybe in the discussion. Now, we also wanted to be sure that this was not an artifact, so we looked at the subgroup of this population who were on DAPT. And again, these patients who were on DAPT, it's almost 600 patients. Again, numerically, the rate of bleeding was slightly lower, 7.7% in the icosapent ethyl arm compared to the placebo arm, 9.4%. Again, granted, this is not statistically significant, but certainly reassuring that there is no excess bleeding in that population. Atrial fibrillation was more frequent with icosapent ethyl, as in the overall trial population, 7.4 versus 2.9. If you look at those that required hospital admission, 4.8 versus 1.7. So to summarize the safety, overall, what we saw was consistent with the overall trial population, including more frequent atrial fibrillation or flutter, but bleeding event rates appear similar in both treatment groups in patients with recent ACS. Now, there are limitations in this analysis. We powered the trial for the overall trial population, not for subgroup analyses. And the data I've just shown includes both pre-specified and some post-hoc analyses. So they have to be interpreted conservatively, particularly with statistical p-values. However, as you've seen, the effects are not modest. They're quite dramatic. So even if you take a conservative view of the statistics, I think the signals for efficacy are quite clear and striking. I also would like to put side by side the various subgroups with coronary artery disease from REDUCE-IT. This is a table that summarizes the event rate in the icosapent ethyl arm and the placebo arm, the hazard ratio, the absolute risk reduction, and the number needed to treat for the overall patient population in red and for 4 subgroups in black. And I think what is most significant, in my opinion, is the absolute risk reduction, because this is really the benefit that patients get from being treated. It's not a relative number, it's an absolute number of events that are avoided over the duration of the trial. So overall, the trial was quite positive with an absolute risk reduction of 4.8. If we look at patients with prior MI, the absolute risk reduction is 5.9. If we look at patients with a history of PCI, the absolute risk reduction is 8.5. If we look at patients with prior CABG, which is a group that we've always known is at high risk, it's 6.2. And if we look at patients with recent ACS, this is, as I pointed out, the group with the largest absolute benefit. The absolute risk reduction is 9.3%, which I think is, I hate to say remarkable, I will say interesting. I think nobody can question that this is interesting, given the relatively good profile of safety of the drug. So the candidates for IPE, given these results, this is the approved, or to be fair, mostly the reimbursed indication. It's statin-treated adults with TGs between 1.5 and 5, LDL cholesterol between 400 and 100, with established atherothrombosis. This is what's reimbursed. But I think the best indication would be the same population, focusing on the hotspots in the data that I just highlighted. Patients with recent ACS first, this is the highest benefit, so it's really a hotspot in the data. And also the group with prior MI, prior PCI, and prior CABG, where you get an even greater bang for your buck than in the overall trial population. So I think if we're going to start somewhere, these are the patients with whom I would start using IPE, although I do believe that the benefit is quite consistent across the trial, including for patients in primary prevention. And I hope that someday we get confirmatory data from other studies that also demonstrate the clear-cut benefit we saw in REDUCE-IT in primary prevention. I think that this would be great for patients if we could expand the scope of prevention to primary prevention. So my conclusions are there's a robust clinical benefit of icosapent ethyl in REDUCE-IT in comparison to the placebo, and that was consistent across various outcomes and various subgroups. I didn't want to go into the details of the study because it's been shown many times already. The safety profiles appears good, but we have to acknowledge that there's an increased risk of AFib flutter, and bleeding risk may be increased overall. It should be used in secondary prevention statin-treated adults with elevated TGs. The greatest absolute benefits are obtained in patients with recent ACS. And really, from what we saw, there is no reason to deprive this population from the benefit of IPE, even when they are on dual antiplatelet therapy or anticoagulant therapy. Questions? I'll stop here and I'll be happy to take questions.
Absolutely. I think it's very interesting. Sure, maybe we have too many, but let's start with the background. Because you pointed out very interestingly that we have a new situation. We don't treat patients right now as we did 10 years or 20 years ago. So it's important to put in context the rest of therapy. For instance, we used to use fibrates for triglyceride-lowering therapy, and we have recent information with the fibrate trial that the fibrates do not seem to have a clear role in this moment. So this is one issue. And the other one I would like you to comment on is that the very same day when your paper was published in the New England Journal of Medicine, the VITAL trial was also published. The results were null. In any event, it was a tendency to have worse outcomes treating patients with another kind of omega-3 fatty acids. So I would like you to put the emphasis on the difference between IPE and other omega-3
fatty acids.
Fatty acid, yes.
Yeah, so I think the omega-3 fatty acid field is interesting because it's very heterogeneous. There's a great diversity of designs, of products that are being tested. There's EPA, DHA, mixtures of EPA and DHA. Most of the trials have used mixtures of EPA and DHA, and most of the trials have used low doses of the mixture. And when you look at the totality of the evidence, the trials that use a low dose generally are negative. And the trials that use mixtures generally have not found a benefit. 3 trials have found clear signals of benefit in cardiovascular prevention. These are JELIS, REDUCE-IT, and more recently the RESPECT-EPA Japanese trial that was presented at the American Heart Association in November 22 and is pending publication. And these 3 trials have an interesting common characteristic. They all used purified EPA alone, not a mixture of EPA and DHA, and they all used at least 1.8 or 4 grams of EPA, so a high dose. And I think this is probably the most important characteristic related to the benefit of the trial. And we have looked retrospectively at the EPA content in the blood, either in the serum or in the plasma, and they're highly correlated, across various recent trials, positive and negative. And what's very interesting is that there are different levels of EPA across populations. For instance, in Japan, they tend to be higher than in Western patients, given the food intake and the fish intake in the food in Japan. But those trials in which the achieved EPA level in the blood was in the range of 140 or more are the 3 trials that reached benefits. All the other trials had lower achieved EPA and they all failed. And within REDUCE-IT, we have presented, not yet published, but we have presented data that shows a very dramatic correlation between the achieved level of EPA in the bloodstream and the cardiovascular risk reduction. And I think it's all about the EPA. So in the end, what matters is the level of EPA you achieve in the bloodstream. If you give DHA, it may be neutral. There's data that even suggests that potentially it could be detrimental, but certainly giving DHA has not been shown or correlated to benefit. It's giving high dose EPA that seems to be beneficial. So I think this is really the most striking difference between the positive and the negative trials.
You raise a question that is quite interesting for us for these acute coronary syndrome patients. No? Surprisingly, you didn't find an increase in bleeding in these patients. And they are taking drugs, a lot of drugs for that. Do you have any explanation?
Yes. The main hypothesis we have is the following. It's been known for many years that EPA and DHA, but mostly EPA, has mild antiplatelet efficacy, mild antiplatelet effect. And there are multiple studies, some of which are quite old, that show increased bleeding with omega-3 fatty acids. But it's a modest effect. So if you look at the overall patient population and REDUCE-IT, many of whom are not on dual antiplatelet therapy, some of whom are not even on any antiplatelet therapy, well, you can discern a modest antiplatelet effect and a modest bleeding risk. If you focus now on patients who have had a recent ACS, most of whom are on potent antiplatelet therapy, sometimes antiplatelet therapy and anticoagulant, but many of them are on dual antiplatelet therapy, well, the cyclooxygenase pathway is inhibited with aspirin, irreversibly once you've taken aspirin for a week. And the P2Y12 pathway is inhibited with P2Y12 blockers. And once you've blocked the receptor for P2Y12, again, it's, except with the exception of ticagrelor, it's irreversible and certainly very potent. And once you've blocked the platelets, well, you cannot see a delta related to the effect of EPA because it's much smaller and much milder. So it's diluted in the efficacy of the antiplatelet effect. So I think that explains why you would see an effect overall in a patient population who's not on DAPT. But once you have blocked the platelets with DAPT, the platelets cannot be blocked anymore. There cannot be an additional delta related to the mild antiplatelet efficacy of EPA. So that would be the hypothesis of why, surprisingly, we didn't see
we can use the drug even more security in this patient than in the general population.
Yeah. The platelets are already blocked, and once you've blocked the platelets, they're blocked.
Nothing else to do. Any other question?
Yeah. There is another question that you have shown us that impressive absolute risk reduction in the global trial, but it's much more dramatic in those patients with a recent acute coronary syndrome. Is there any reason, or just it is because of the higher risk in the short term after the acute coronary syndrome? What will be your explanation? Is there anything unique regarding this population?
So I think it's, I think the relative risk reductions tend to be quite consistent across subgroups. They're generally highly transferable. And the difference that we are seeing within the trial may be related to chance fluctuations. you divide a highly positive trial into subgroups, and some will be 35, some will be 20, and the average is 25. That's what we see. The absolute risk reduction tell us about the drug effect across risk subsets, and they tend to be more specific to patients. And so I think that what we're seeing is first and foremost the reflection of the highest risk of these recent ACS patients. So I'm not sure that the drug is more effective in these patients. I think it just works just as well as in everybody. But because these patients' baseline risk is so much greater, the absolute risk reduction is greater. Now, I will grant you that when you do the formal comparison, the hazard ratio is lower in that patient population, but I'm not sure this is very important or that it actually is not a chance finding. It might be a chance finding, but there's no question that the absolute risk is so much greater in recent ACS patients that even if you get the same relative benefit, you'll get a greater absolute benefit in that patient population. And that tends to be generally true with any intervention.
But this raises the issue that we shouldn't be waiting for patients having new events to treat them intensively from the very moment we have detected the disease.
Absolutely. I think that if you look at the 4 subgroups I highlighted among coronary artery disease patients, recent MI, history of PCI, history of CABG, recent ACS, history of MI, recent ACS, and any revascularization, it's a good way to identify high-risk patients who will derive great benefit. And this represents a large fraction of patients in secondary prevention, and this is where I would start.
Could you speculate about the role that triglycerides play in this movie? Because we use triglycerides, but as far as I know, there is no relationship between the effect and the reduction in triglycerides that is modest.
Yes.
So
omega-3 fatty acids have a modest triglyceride reducing effect. It's highly statistically significant.
Oh, sure, about 20% or something.
But it's modest. And much to our surprise, when we looked at the correlation between triglyceride levels at baseline and benefit of the treatment, there was none. Mm-hmm. And even when we looked at achieved triglyceride levels after 1 year and subsequent benefit, there was no correlation either. So what happened is that we used triglycerides to identify a high-risk patient population with residual risk, but it doesn't appear that triglycerides are key in explaining the benefit. Does this mean that triglycerides play no role? I'm not sure. In fact, when we do multivariate modeling and do what we call a mediation analysis, and I will grant you that mediation analysis can be more an art than a science, but when we do mediation analysis, some fraction of the benefit seems to be explained by triglyceride, but it's a very modest fraction of the benefit. The bulk of the benefit comes from changes in EPA and arachidonic acid. So it's really the omega-3 fatty acid that counts.
Triglycerides are then a marker of disease rather than the mechanism by which the drug is acting?
That's exactly.
Could you envision for the future potential treatment with EPI or in patients with increased inflammation but with normal triglycerides?
I think that's a tantalizing hypothesis that deserves to be tested. I would love to do that trial. I think it'd be a nice companion trial to reduce it, but I think we cannot derive insights from reduce it to make any conclusion about this. So I wouldn't treat patients yet like that, but I think it deserves to be tested.
What do you think could be the exact mechanism of action of eicosapent ethyl? Because when you look at the curves, you see that have to wait 1.5 years to see them to separate. Probably it's not antithrombotic, something related with lipids, more probably, but you have any clue about that?
Yeah, so what's interesting is there have been other studies looking at mechanisms, particularly plaque evolution on omega-3 fatty acids. Again, our Japanese colleagues did a very interesting IVUS study called CHERRY EPA, where they administered EPA versus placebo or versus control. I think there's no placebo. I think it's an open label trial. And they measured plaque volume after 18 months and 24 months. And what they found is that it took 18 months for plaque changes to appear. So I do believe there are changes in plaque and it takes a while for them to accrue. It's noteworthy that in RESPECT EPA and in JELIS also, the divergence of the curve took a while. So I think this seems to be a consistent pattern across the various EPA trials, that the benefit does not emerge in the first few weeks. It takes a while for it to appear, suggesting that it may be an atherosclerosis-related benefit. That being said, I'm not sure there's a single pathway for benefit for APA. There are a myriad potential pathways of benefit, plaque stabilization, membrane stabilization, antioxidant effect, improved endothelial function, antiplatelet efficacy in those patients who are not already on antiplatelet therapies, and so on and so forth. So we don't really know if there's one mechanism, and it's completely possible that there might be multiple ones. But it seems to take a while, suggesting that it's more atherosclerosis related than hemodynamic or thrombosis related.
Do you have an idea about, in your clinical practice, how many patients could meet the inclusion criteria?
Yeah.
We have, so far we have cleared that acute coronary syndrome patients are probably the principal target, and among them, which one could be?
So we looked in a couple of registries of patients with stable coronary artery disease or secondary prevention, and we looked at how many patients would fit the bill of the inclusion criteria in REDUCE-IT, and it's generally in the range of 15 to 20%, no more. If you look at patients in secondary prevention who have the LDL between 40 and 100, are on a statin and have elevated TGs between 150 and 500. Of course, we could focus further on recent ACS, recent MI, etc. But if we look at the totality of the secondary prevention cohort of REDUCE-IT, it's 15% to 20% of all patients with secondary prevention.
Okay, a significant number of patients.
Yeah, 1 in 8.
That.
Yeah, 1 in 8 patients. So it's not negligible.
Any final comment? Because no, but go ahead. Just quick question, quick answer.
Okay. The question is that another potential source of concern was the increased rate of atrial fibrillation. Yeah. But at the same time, there's a reduction in sudden cardiac death. So I would like to comment on this too.
Yeah. So thank you for asking the question, because I did mention one important thing. There's no question there is an increase in AFib flutter. It's very true. It's very consistent across trials. It's dose related. I think there's no question it's true. It's modest, but it's true. But as you point out, sudden cardiac death is reduced, and more importantly, stroke is dramatically reduced, including ischemic stroke. And I think some people tend to forget this because they are concerned with the AFib leading to stroke, but stroke is markedly reduced. So I think we shouldn't lose track of that. We also looked at patients who were in AFib at the onset of the trial, at baseline. Did they derive the same benefit as the overall patient population? And the answer is yes. We also looked at patients who developed AFib, incident AFib on treatment. Did they derive the same benefit as the others? The answer is yes. So we should not deprive AFib patients from the benefit. Having AFib is never a good thing, but it doesn't mean that the drug doesn't work or doesn't protect you against stroke or cardiovascular events.
Muy bien, yo creo que ya hemos completado nuestra revisión de los datos presentados por el doctor Steck. Yo quiero agradecerle su magnífica presentación, también las cuestiones planteadas y su presentación por el doctor Guijarro. Y simplemente finalizar que hemos visto, recordar que cuando salió el REDUCE-IT había una editorial acompañándola por el doctor Castellane, que decía que veía los datos con sorpresa, especulación y esperanza. Y yo creo que todavía tenemos alguna sorpresa más en pacientes con síndrome coronario agudo. Especulamos todavía sobre el mecanismo, pero sí que tenemos claro no ya la esperanza, sino la certeza de que muchos pacientes, que vamos enfocando ya en pacientes con síndrome coronario agudo, se pueden beneficiar del uso de esta medicación que tenemos con nosotros desde hace algunos meses. Y esto es todo por nuestra parte. Muchas gracias.